So, Srijan, there's a
Yes, sir.
slide that you will be put. I have done my part, right? So it will come
Yes,
again.
sir. I will put up on the screen. So, sir,
Okay.
we are on live. So, good
Yeah.
afternoon, everyone. This is Shreyan from IGCP, today's moderator. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker, doctor, for today's session. With much pleasure and honor, let me welcome a very renowned doctor, Dr. Gaurav Bhaduri. Sir is MBBS MD, SCE Endocrinology and Diabetes, PG Diploma in Clinical Endocrinology and Diabetes from Royal College of Physicians, UK. Sir has also done CCDM, FICP, F Diabetes Consultant in the Department of Diabetes and Endocrinology at Parkview Super Speciality Hospital, Kolkata, and Apollo Sugar Clinic, Newtown. Now, with the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is twin diabetes, Twindemic of Diabetes, Challenges and Solution. Now, without any further delay, I would like to welcome Sir again at our forum and would like to hand over the session to him. Over to you, sir.
Yeah. Thank you, Srijan, for the very kind introduction. Can I have my slides up there? Yeah. So, first of all, my thanks to the organizers of MedTalks for inviting me to talk on this topic of twindemic of diabesity, the challenges and the solution. So, what we are going to discuss today, we have divided into 8 parts. So, we are going to talk about the epidemic of diabetes and obesity, and then we are going to talk about the overlap of diabesity, followed by the epidemiological trends and the regional variations that comes with this problem. Then we'll discuss a little bit about the pathophysiological links between obesity and diabetes, and then we take forward to the public health and clinical challenges that we doctors face and the solution and the interventions that we can take to combat this issue. Finally, we'll conclude with future directions, and I will present one case of diabesity to address that how with the current armamentarium what we have with us, how we can tackle those issues. So coming to diabetes, the total global prevalence, if we look at it, so it has doubled since 1990. So in the last 35 years, from 7% prevalence, we have gone to 14%, with the WHO saying that we have around 828 million adults living with diabetes worldwide, which is a huge number. And if you look at the IDF data, it says that in between the age of 20 to 80, it estimates around 589 million people living with diabetes. Now, the historical trend hasn't been very nice. So the cases have risen from 200 million in 1990 to around 828 million by 2022. So that's been a fourfold increase in diabetes over the last 3 decades. Not only that, there has been undiagnosed and untreated cases, especially in the low to middle income countries. If you look at the data, it suggests that nearly 59% of adults aged more than 30 years with diabetes, roughly around 445 million people, received no treatment as of 2022. The regional equity, if you look, so approximately 81% of the diabetes cases in the age bracket of, again, 20 to 79 occur in low and middle income countries. And remember, these are resource limited setups. Now, coming to obesity, we have again around 879 million adults living with obesity with a BMI of more than 30, which is usually used to define obesity in the Western part of the world. In India, the BMI of more than 25 is considered as obese. So here we also need to take into consideration of that fact. Now, this reflects an age standardized obesity prevalence approximately 15.8%, up from 6.6% in the 1990s. So we can see not only diabetes, there has been a very, very sharp exponential increase in obesity as well. Only the adults are not involved. Those are childs and adolescents are not spared. So approximately 159 million children and adolescents aged 5 to 19 years were living with obesity as of 2022. And now if you combine the total adult and the young population, it's about a billion people worldwide living with obesity. Now, this dual burden of excess body fat is the primary risk factor for the type 2 diabetes. The phenomena of overlapping obesity and diabetes, now termed as diabesity, that's the topic of our talk today, is now recognized as a distinct global epidemic. Now, it is very difficult to estimate how much is the overlap. However, a 2023 Global Burden of Disease study indicated that approximately half of the type 2 diabetes patients that we have are actually obese. So there is a conservative current estimate of around 400 to 500 million people living concurrently with diabetes and type 2 and obesity. Now, this overlap of diabesity is parallel but converging epidemic. So, diabetes and obesity affect a similarly large adult population of around 800 to 900 million. They share the common drivers of urbanization, sedentary lifestyle, and unhealthy diets, and a swiftly becoming entrenched public health crisis. Now, there is an interlinking in the pathophysiology we are going to discuss in the later slides, with half of all the type 2 diabetes burden directly linked to high BMI, and the conceptualization of diabesity, this terminology has come to look at the scale of comorbidity that demands integrated healthcare strategies. Now, there has been a rising youth onset of this problem, with childhood obesity quadrupling since 1990. Type 2 diabetes is emerging earlier, carrying lifelong cardiovascular and the metabolic risk. Now, there has been some epidemiological trends and the global trends we already discussed, but there are certain regional variations. So, if you look at the regional disparities, so in 2022, the regions such as Southeast Asia and the Eastern Mediterranean exhibited adult diabetes prevalence rates near 20%. So, extremely high numbers. And the low middle income countries now represent approximately 81% of the global diabetes burden. And there is significant disparities in awareness and access to care in this part of the world. Around 450 million adults with diabetes remain untreated, we discussed previously, and that is 59% of the adult diabetic population, which is largely concentrated in these low middle income countries. Now, the age of onset trends, again, we have discussed already, but remember that historically considered a disease of the older adults, this type 2 diabetes is now emerging much earlier, with the rising incidence in the population aged as early as 10 to 24 years. Now, if you look at this data on the left-hand side, you can see the data from the ICMR India B study, which showed us a prevalence of generalized obesity at around 28% and abdominal obesity at around 40%. So that's the concern for India. And if you look at the right-hand side, you will see that this projected number for men, women, boys, and girls, they are rising very, very, very sharply over the years and decades. So it's a decadal problem, and we need to take some steps to, address this particular issue. And if you look at the overweight impact on national GDP, it's 1.8%. That's very, very high. So there's an economic aspect of this challenge that we have here in India. Now, the childhood and adolescent trends which we're talking about, so if you look at the children aged in between 5 to 19 years, obesity prevalence escalated from 1.6 to 6.9% in girls and from 2.1 to 9.3% in boys from 1990 to 2022. And childhood thinness actually decreased substantially, and obesity surpassed thinness in 67% of the countries for girls and 63% of the boys by 2022. Even in India, the underweight problem is dipping and the overweight and obese problem is increasing. So this is a concern. So what are the key takeaways from the trend analysis that we have done? That rapid global escalation, both diabetes and obesity rates have climbed dramatically since the 1990s. The lower middle income countries disproportionately affected, with LMICs now facing the highest growth rate in both diabetes and obesity. The youth onset diabetes, rising type 2 diabetes is increasingly diagnosed in adolescents and young adults. Coming to geographic hotspots, remember, most dramatic obesity and diabetes increases are seen in the Southeast Asia, the Eastern Mediterranean, island nations, and the MENA regions. So there is an overlapping trend. The obesogenic environment accelerates the diabetes risk. Now, coming to the pathophysiological links between obesity and diabetes, I will very shortly take you through this. So, adipose tissue acts as an endocrine organ. So, there are adipokines which are being released, which actually modulates the appetite and the metabolism of the body. So, secretion of bioactive substance include leptin, adiponectin, and the pro-inflammatory cytokines like resistant and TNF alpha and IL-6. Now, insulin resistance also plays a very important role. So, obesity leads to an ectopic lipid accumulation interfering with the insulin receptor signaling. And the consequence is sustained insulin resistance places excessive demand on the pancreatic beta cell, leading to hyperinsulinemia and eventually the beta cell exhaustion. Now, coming to the inflammatory pathways, which also play a very important role. So, there is adipocyte hypertrophy, causing hypoxia, macrophage infiltration, and activation of the nuclear factor kappa beta pathway. And the increased secretion of these inflammatory mediators interferes with the insulin signaling and impairs the beta cell function, and they affect them directly. Then there is the component of lipotoxicity and the ectopic fat deposition. So what happens is that excessive fatty acid influx leads to a mitochondrial dysfunction, endoplasmic reticulum stress, and apoptosis of beta cell, accelerating the progression to type 2 diabetes. And finally, we also have the gut microbiota and the metabolic inflammation. So alterations in the gut microbiota composition contribute to systemic insulin resistance and metabolic syndrome. So in obese patients versus non-obese patients, so there is a difference in the gut microbiota. And last but not the least, we have the genetic and the epigenetic interactions. So genetic variants and epigenetic modifications influenced by maternal obesity and early life nutrition also predispose to diabesity. So these are the pathophysiological links between the diabetes and obesity. Now, coming to the real world public health and clinical challenges. So we have discussed about the rise in clinical demand. So diabetes related healthcare cost is projected to surpass $1 trillion annually by 2030. So you can imagine we are aspiring to be from 4 trillion economy now to maybe 5 trillion. So, but the global cost of diabetes is going to touch that $1 trillion. Now, complex care pathways is also a problem because effective management spans multiple specialties requiring integration to avoid a fragmented care. And this also increases the cost for the patient. Coming to the access and the equity in the low middle income countries, so there are treatment disparities. We have talked about that 59% of adults more than 30 years of age with diabetes actually receive no treatment. Can you imagine we are living in 2020s? So the obesity care gap, so the bariatric surgery and medications like the GLP-1 agonist or the dual GLP-1 GIP agonist that we have here now are often unaffordable or inaccessible. So there is this obesity barrier for, in terms of treating the patients with the adequate mechanism. The prevention shortfalls is that the urban planning discourages physical activity. So we don't have much of parks or playgrounds for the children to, the way we have been brought up in our childhood. So that kind of playgrounds are diminishing. And then there is easy access to energy dense food, and this is proliferating over the years. And the policy implementation for taxation on sugar, sweetened beverages, and food marketing restriction is lagging. And this is lagging across the globe. Then very important is the social determinants and the stigma. The socioeconomic inequities and the weight stigma also creates a barrier to effective obesity care. So patients, because of the stigmatization of obesity, are sometimes not willing to seek advice from healthcare professionals. The clinical therapeutics and adherences again plays a big role. So the legacy medication agents often lacks the potential to achieve normal glycemia or HbA1c of less than 7%. And then the adherence challenges include side effects and injection fatigue for GLP-1 receptor agonists, which are mostly injectable, specifically if you're talking about obesity management per se, then all the agents are injectable as of now. Now, the solution and the interventions, what we can offer. So individual level interventions are important, as well as the population level interventions. So first, let us talk about the individual level interventions. Lifestyle modification remains the cornerstone. So weight loss programs, diet, exercise, and behavioral therapy, and this needs to be reinstituted towards the patient, remotivating the patient at every visit regarding the lifestyle modification, because data has been telling us that in terms of body weight management, 80% of patients who are on lifestyle programs, they lose their body weight, but they go back to their original body weight within 5 years. So 80% of the patients will go back to their original body weight within a span of 5 years. So it is not sustainable, and mostly because the reinforcement is not happening, and the patient loses motivation for lifestyle modification. So this is sometimes not very easy to say, but very difficult to actually implement and do for the patient. So then comes the role of pharmacotherapy. So GLP-1 receptor agonists have actually changed the entire landscape of the weight management, and they can achieve significant weight loss and HbA1c reductions. But yes, there are certain barriers to GLP-1, like we talked about injectable, it being the cost of therapy that's associated with it, and then the long-term adherence that comes with any medication. Then the metabolic surgery, the bariatric surgery, they can lead to dramatic improvement in body weight. Probably the best weight loss is seen with metabolic surgery compared to lifestyle modification, even pharmacotherapy, though the pharmacotherapy is rapidly trying to achieve a level of metabolic surgery endpoints. But metabolic surgery again has got many limitations. As a surgical procedure, costly, it requires a multidisciplinary team to maintain the body weight even after surgery, and then there is a risk of micronutrient deficiencies, which all needs to be taken care of. Now, as a healthcare system strategies, we need integrated chronic care models. So the coordinated multidisciplinary teams for holistic care is very much in need in today's world. And then capacity building in the lower middle income countries. And we need to task shift from ACPs to community health workers and expanding the telemedicine network so that we can reach out to more and more people. The population level and policy interventions are probably one of the most important areas, which is often overlooked. So first of all, the sugar sweetened beverage tax, the SSB taxes leads to reduction in consumption associated risk. For examples include the Mexico's 1 peso per liter tax is already implemented. The front of pack leveling and the marketing restrictions, so most of the time the label is there at the back of the pack, so the labels should be at the front of the pack, and interpreted labels and advertising restrictions to promote healthier and dietary behavior can actually tackle this issue to a certain extent. Now, coming to the urban design and the education policies, so activity-friendly infrastructure is the need of the hour, and school-based programs so that children learns from the very, very early stages of their life regarding the importance of a healthy lifestyle. And then subsidies and counter marketing. So subsidies for fruit, vegetables, and whole grains are very important. So you tax the sugar and you subsidize the healthy foods. So that's going to promote a much better healthy culture. And mass media campaigns. So the media plays an extremely important role in terms of campaigning for a healthy lifestyle. And then we go into multi-sectoral partnership and governance. So individually, we have talked about 3 different levels, and then we need to get together our act in terms of collaborating them all together. So engagement from government, industry, civil society, and academia, they all need to come together. And there is a need for a real-time surveillance to monitor the diabesity trends and policy impacts. So whatever policy you take, whether that's impacting the real world scenario or not, so you need a real-time surveillance to monitor the trends of diabesity. Coming to the conclusion and the future directions, so diabesity represents a pressing public health challenge driven by the common determinants as we have discussed. So the key challenges, again, are the overwhelmed healthcare system, particularly in the LMIC, underutilized pharmacological and surgical advances because of cost, access, and the side effects of sometimes the advances that have come. Social determinants and weight stigma are limiting and a very important challenge because patients sometimes do not seek care because of weight stigmatization. So there needs to be more of engagement and care, and delayed policy interventions should be looked upon. And the faster policy interventions we can do, and have a feedback mechanism where we can assess the change in trends upon a policy implementation to improve upon the policy interventions is also very important. So the future directions are embedded diabesity in USC frameworks, scale up preventive policies like the SSP tax and the front of package labeling, invest in robust surveillance in the research, strengthen the multi-sectoral governance and try to collaborate each segment with the other, and reframe the societal perception to destigmatize obesity. And this is what we need as of now. So, in final conclusion, diversity reflects the breakdown of the modern food system, the urban design policies, and the global health equity. The challenge requires collective will and interdisciplinary action to translate evidence into impactful interventions for our future. So, coming to a case presentation, and after that, we'll take question and answers from the audience. So this is the patient, Mrs. SB, aged 55 years, type 2 diabetes since last 30 years, primary hypothyroid since last 20, and hypertension for last 8 years. The BMI is 34.8, clearly obese, weight 83.7 kg, height 155 centimeters, blood pressure well controlled at 122 by 70 millimeter of mercury. So current medications when the patient came to us had a IDEC ASP of 60 units in the morning and 50 at night, glimepiride 3 milligram, metformin 1 gram twice a day, sitagliptin 100, dapagliflozin 10, and pyriproxine 30, almost everything given to the patient. Now thyroxine 88 microgram, telmisartan 40, cilnidipine 10, and metoprolol 50 milligram once a day, and rosuvastatin 20 milligram. And initial lab findings tells us that the fasting was 156, the PP 252, HbA1c 7.7. So even after using, 1, 2, 3, 4, 5 oral medications and insulin, 110 units daily, the patient was unable to achieve the HbA1c target of less than 7. And the triglycerides was 191, the LDL was 57, well controlled LDL. And the AST was 27, ALT 43, GGT 88. So raised liver enzymes, creatinine normal, urinacea normal, TSH well controlled. The FibroScan tells us LSM of 9.6 kPa elevated, and the cap at 316 dB per m. Now the medication change, what we did was we removed the glimepiride and the sitagliptin. IDEC as was reduced in a preventive way to 45 and 35 units at night, 45 in morning and 35 at night, because we were planning, or we actually started tirzepatide at 2.5 milligrams subcutaneously once a week to reduce the body weight of the patient as well as a better sugar control. And daily SMBG was suggested to the patient. So let's have a look at what happened. So 2 weeks from the first visit, a patient started experiencing hypoglycemia, even though we had cut the glimepiride completely, and we had reduced the insulin also very, very sharply. We have reduced it, even though the patient experienced hypoglycemia in fasting and post-lunch SMBG data. So IDEC was reduced by telemedicine to 30 units in the morning and 30 at night. 4 weeks from first visit, now the patient has no further episode of hypoglycemia, and the Mounjaro was decided to be increased to 5 milligram now, because 4 weeks have passed and the patient was tolerating it, albeit there was some nausea on the patient, but no major serious adverse events happened. And that's expected also, that some degree of GI side effects will happen with tirzepatide. So 5 milligram, it was increased to 5 milligrams subcutaneously once a week, and IDEC ASP was further reduced because you're increasing the tirzepatide, so it was further preventively reduced to 25-20. And what we actually got at 4 weeks, let's have a look at that also. So we had a fasting now at 134, the PP at 168. The HbA1c has dropped by 7%, 0.7% in just 4 weeks. So from 7.7, it has come to 7%. in only 4 weeks. And the triglyceride from 191 to 157, the LDL was constant at 57, the body weight was 82.1. So mild reduction in the body weight has also started. So 8 weeks from the first visit, the Mounjaro continued at 5 milligram once a week because the 7.5 had not come yet. The IDEG AS was reduced from 20 units in the morning to 20 units at night. If you look at the data that the patient came at 8 weeks, is fasting has come down to 74, the PP at 123, the HbA1c 6.7, the AST 29, ALT 32, GGT 43, the so liver enzymes has also improved, and the body weight is right now 78.2. So from 83.7 to 78.2, around 5.5 kgs drop in body weight has happened. And the patient was also, reinforced with dietary advices and physical activity. So the patient was actually not on a very bad diet. So patient was also already trying every bit with insulin, with all 5 medications, and following the diet. Exercise, the patient was doing a little less, so we included a little bit of muscle strengthening exercise along with aerobic exercises. But the result was very, very good. So in 8 weeks, we could get about more than 5 kg body weight loss. And the patient is still on this, so we will be following up this patient also later. But we got a fantastic result in terms of insulin reduction. So from 110 units every day, the patient is now receiving about 40 units of insulin every day, glimepiride completely gone, and then the sitagliptin is also not there. Instead of that, the tirzepatide is being used in this patient. So we got a very good result in terms of body weight loss, and that is probably the driver of why the blood sugar came down so well and so fast within very few weeks of starting the treatment. So in rightly selected patients, these GLP-1 agents can be of great use. Yes, these are injectable, though this is only once a week. But the main issue is cost here in India. So in patients who can afford, this can be a good strategy of using the GLP-1 receptor agonist or the GLP-1 GIP co-agonist to tackle this issue of diabetes in some of our patients. But lifestyle remains the cornerstone in such scenarios. So I thank you very much for your patient listening. I'm here if you have any questions for me.
Thank you so much, sir, for this wonderful presentation. We do have some question if you like to take that up.
Yeah, sure.
Yeah. So, sir, the first question is, how does insulin therapy affect weight gain in diabetic patient and how it can be mitigated?
Yeah, so insulin will lead, because insulin, where you are giving it, remember, it's a anabolic hormone. So it will lead to weight gain and mostly the fat gain. Okay, so yes, if you are using this in a patient who has lost a significant amount of weight because of glucotoxicity, then probably when you start using insulin, there will be some muscle gain also because of the anabolic component. But in usual, when you're using this in an obese patient, the weight gain will happen and mostly the fat gain will happen. And so that is the reason why in obese patient, we don't want to use insulin as the first line of therapy if the oral agents are failing. So in those situations, it's best to use a GLP or a GIP co-agonist to tackle the issue of obesity, because insulin will lead to some amount of weight gain. However, the problem currently is that these agents which are there are costly, and they're injectable and they're costly. But with the advent of once a week, and still costly, but with the advent of once a week GLP GIP coagonist, or the semaglutide GLP is also launched in India right now. It has been launched today. So because of these two agents, we will be able to tackle now better in these situations. The oral GLP semaglutide was already available. For diabetes, that was there, but for only management of obesity, that was not approved. But for diabetes, it was there. So we were using it already. So you try to use these agents upfront in patients with the issue of obesity before using an insulin. Once, if you can't still manage it, or if the patient still needs insulin, then probably the role of insulin is there. albeit some weight gain will happen with that.
Next up, sir, we have another question. In your experience, how often is diabetes underdiagnosed or misdiagnosed, especially in rural or primary care settings?
Yeah, so that's a big issue because though the obesity trends are increasing also in the rural, but in the urban centers, the obesity is a bigger problem than in the rural. There's no denying that fact. But even if you look at the rural trends, you will also see that the rural rate is also increasing because of the similar kind of lifestyle now penetrating from the urban to the Tier 2 and the Tier 3 cities and then into the rural areas. So this is a pan-India problem, a little less probably in the rural, a little high in the urban centers, but the rural is not spared. So what you need to do is that at least have a BMI measurement, because that's the easiest thing to do to understand the obesity status of the patient. Though it's not the best or the ideal tool. In India, ideally, you should be doing the waist circumference because that is where the central adiposity is there. And if you miss the waist circumference, sometimes you will miss a lot of cases of obesity. Because in the study, I showed you the ICMR India B study, it showed us that the generalized obesity as per the BMI was 28%, but when abdominal obesity was included, which is more than 80 centimeter of waist circumference for women and more than 90 for men in India. This is for India. So this cutoffs you need to use, and then if you see that data, it says 39.5%. So almost 40% people are abdominally obese here in India. So you try to measure the waist circumference, at least do the BMI, try to measure the waist circumference. What we are doing in our setups, so these are advanced tertiary setups, so we are doing the bioelectrical impedance analysis to understand the fat muscle composition. In patients where we need more detailed analysis, we are doing a DEXA to understand the body composition. So we are doing it. So pre-therapy and post-therapy also we are doing it to see how much of the muscle mass is lost. And sometimes we also not only try to evaluate the muscle loss, because some amount of muscle loss will happen whenever the body weight falls. So whatever mechanism you use, whether lifestyle or even the medication, some amount of body weight, muscle mass loss is going to happen. So you need to take care of that by doing more of resistance training. And remember, the numerical muscle mass loss is less important. More important probably is the functionality of the muscle. But recently in ADA, just yesterday actually, ADA, they presented this paper where they're trying to combine a monoclonal antibody bimagrumab along with semaglutide. So this bimagrumab alone study that they have shown that there is an increase in the muscle mass of 3.6% after using this weight loss agent. So it is losing weight and it's increasing the muscle. So, but whether this increase will functionally, how much important is need to be evaluated later in the study, and then they try to combine it with GLP-1 agonist along with the bimagrumab, so that the muscle loss that happens with these therapies can be taken care of. These are still in the nascent phases, but in the future, probably we will have agents which will take care of the muscle loss in our patients.
Thank you, sir. We have one last question. Are there specific glycemic target for obese diabetes patient that differ from standard guidelines?
No, see, the target should be very, very similar. So there's only because if you have obesity, you have a different target. That's not the situation. But what happens sometimes is that if you have a very high, body weight and your obesity is very high, you might have a very high insulin resistance. So sometimes when we are using agents, and if the diabetes is of long duration, like in this patient, sometimes the risk or the glycemic variability increases because of that. So you need to use agents more which has a lower glycemic variability. So like we shifted out the sulfonylureas here from this patient, mostly because we didn't want more of glycemic variability in this patient. So we wanted it to be tackled with agents like tirzepatide instead of a glimepiride. So but insulin again is there in this patient. We haven't been able to reduce it completely or take out the patient completely off insulin. Maybe when we increase from 5 to 15 milligram once a week, we might even have to take out the completely, we can take out the insulin, and that would make the patient's glycemic variability even better. So if you have a patient with very high glycemic variability, in those situations, if the risk of hypoglycemia is too high, then you might tweak the target HbA1c for that patient, depending on the case-to-case scenario.
Thank you so much, sir, for answering all our questions. That's all from our audience. Before concluding, sir, any take-home message?
Yeah, so what I would suggest everyone is to measure the BMI. So BMI is the least I am saying that you can do. I put it up in your prescription. So, like we say, for don't mention only creatinine, mention the eGFR in your prescription. So, similarly, at least mention the BMI in your prescription. You just need you have the calculator apps in your phone. Just put in the body weight and the height. It will come. If you have a setup, if you have assistant, at least train them to measure the waist circumference. So, BMI basic, preferably at least a BMI plus the waist circumference, so that you don't miss those 28 and 40. So you see there is a 12% cases you will miss if you only measure the BMI. So those, to catch those patients, measure the waist circumference also. If you're working in a setup where you have affordable patients and the clinic has those setups of measuring the body composition, then you should ideally go ahead and do that. And starting the treatment, whatever treatment you are giving to the patient, even if it is lifestyle, and then later on you can check and see the muscle and the body weight composition. Because sometimes what can happen in young patients specifically, they're losing the fat mass, they're exercising and doing resistance training, so they're getting muscle mass. Their weight overall may not come down that drastically, so they're worried that I am doing everything perfectly, and I am exercising, I'm in the gym, but my body weight has not reduced much, sir. So what is happening? So then we show them, see, your muscle has gone up, your body fat has gone down, and this is the perfect thing that can happen to you. Do not worry only on the body weight then. So the body composition analysis gives you a more detailed analysis on the actual situation of the patient. So if you have that technology available with you and affordability of your patients there, then you can do that. But at least a BMI and a waist circumference is almost, these two things are mandatory in your practice to tackle the issue of diabesity.
Thank you so much, sir, for joining us today. It's a pleasure to have you here, and thank you for this wonderful session. Thank you, sir.
Yeah. Thank you, Shreya. Thank you. And thanks to all the doctors